Module 5, Respiratory. This recording is going to focus on Chapter 23, Assessment of Respiratory Function. And we're going to start off with a short video just to remind you how we breathe.
When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
So we're starting off with the anatomy and functions of the respiratory system. These concepts were reviewed in health assessment and foundation, so hopefully this is just a review for you. So let's follow the path of air through the respiratory system. So air first begins in our upper respiratory system, which is either through the nose or the mouth. And remember, our innate immune system is already here waiting for pathogens to come in so it can block them. That includes our saliva that has enzymes, our nose that has hairs, and then here in the sinus cavity, air comes in to get warm and humidified before reaching our lungs. It's going to pass down through the nose, through the mouth, through our sinuses, down our pharynx, where then it will encounter our tonsils, which are also part of our immune system that also help to trap microbes, down the larynx, and then it enters the lower respiratory system, which will be the trachea, the bronchioles, down into the lungs. So that is the path of air through our respiratory system. So now let's briefly go over the functions of our respiratory system. So first we have ventilation. If you remember, that is just the air coming into our lungs and the air leaving our lungs. So inhaling and exhaling. Then we have respiration. So respiration occurs at the alveoli level where oxygen and carbon dioxide are exchanged, okay, where there's red blood cells and alveoli, those little capillaries where they meet, this exchange occurs. This also comes into play with our acid-base balance. The exchange of this carbon dioxide for oxygen in combination of our kidneys secreting bicarbonate help to regulate our body's pH, okay? And our normal pH in our body is 7.35 to 7.45. Other functions of our respiratory system that we may not necessarily think of right away is speech. Okay, the movement of air through our vocal cords allows vocalization of words and speech. Sense of smell, the movement of air through the nose will allow us to smell odors in the environment. And then also of note is fluid balance. So water is excreted as water vapor when we exhale. Okay, so we also take that into consideration with our body's fluid balance. Next is the physiology of the respiratory system. So we have inspiration. And when you look at this picture here, the first one here, inhalation, okay, the same as inspiration. In order for ventilation to occur, there has to be movement of our diaphragm. Our diaphragm is this muscle right here, and it separates the lungs from our abdominal cavity. In order for inspiration to occur, there has to be stimulation of the phrenic nerve. So the phrenic nerve is responsible for the movement and contraction of the diaphragm. Then we have expiration. So expiration is a passive process that happens when the diaphragm relaxes. And as the diaphragm relaxes, there's pressure exerted on the lungs by the chest and abdominal cavity. This will decrease the size of the thoracic cavity and it causes an increase of pressure within the lungs that will exceed atmospheric pressure. This causes air to passively leave the lungs and we exhale it. Okay, then we have respiration. So again, respiration is exchange of oxygen and carbon dioxide at the alveolar level. And then we have dead space shunt ventilation perfusion mismatch. And we will talk about this on a different slide coming up. Next is a review of the lobes of the lungs. And I hope this is a review and everybody remembers that our right lung has 3 lobes. So you should remember that when you're auscultating for breath sounds, that there is an extra lobe in there that you need to make sure you get a good listen to. Then we have cilia. So cilia are like these little hairs that you would picture kind of waving around, kind of like in the ocean. And the movement of mucus and bacteria or even debris on the cilia is kind of like an escalator. It kind of just pushes it out of the body so we can cough it up and spit it out. We have our terminal airways. So this is where gas exchange takes place. Okay, this is the alveolar level, and you can see the alveolar sacs here. We have pleura and our pleural space. These are membranes that cover the lung and chest cavity, the parietal and visceral pleurae, and the space in between, which is the pleural space. Here we have the muscles of respiration. So the movement of the diaphragm and muscles of respiration during inspiration decrease the pressure in the lungs to below atmospheric pressure, which allows for an influx of air. And then when we exhale, the diaphragm relaxes, and then that increases the pressure in the lungs, and then it allows the air to passively exhale. So ventilation perfusion mismatch. This is a very interesting topic. So alveolar gas exchange depends not only on ventilation of the alveoli, but also on circulation of blood through the alveolar capillaries. So in other words, it depends on both ventilation and perfusion, because if you breathe in oxygen, you have to have the red blood cells, the blood, to be able to pick it up. That is perfusion. So you need both oxygen in the alveoli and adequate blood flow past the alveoli to pick up the oxygen, or otherwise the oxygen can't be delivered to the cells and the tissues and the organs that it needs to go. So when that balance is not there, when something happens between the ventilated alveoli and the good blood flow through the lungs, then we call that a ventilation perfusion mismatch. And that's usually referred to or abbreviated as VQ, so VQ mismatch. There are 2 types of mismatch. On the previous slide, it was mentioned dead space and shunt. So those are the 2 types of ventilation mismatch. So one important contributor to ventilation perfusion mismatch is dead space. So dead space is the portion of the respiratory system where tidal volume doesn't participate in gas exchange. So that means the air you're breathing in, not all of that air is actually used at the alveolar level. Some of that air just comes in and doesn't do anything for us, and then it just leaves. So that area that it accumulates is considered to be dead space. Then we have shunt. So another contributor to ventilation perfusion mismatch is shunt. Shunt is the opposite of dead space, and it involves alveoli that are perfused but not ventilated. And these, as you can see in the picture, will typically occur because of some type of blockage. You see here there's a blockage of the alveolus. Okay, this is a shunt. And then here we have a blockage of blood flow, which is ventilation without perfusion, dead space. So it just depends. And these VQ mismatches can lead to hypoxemia. It can lead to accumulation of carbon dioxide. So it's important that we are aware of what this means. Next is history of present illness. So this is when a patient presents with some type of respiratory complaint. We need to make sure that we ask the right questions. So first off are factors that exacerbate or improve symptoms. So we should ask the patient, when do these symptoms start happening? What are you doing? Do they get better when you rest? When do they get worse? What do you do to help them get better? So when symptoms don't improve at rest, that usually means that the patient is sicker than if they did improve with rest. So that's just clues that you can get to find out what's going on with the patient. When it comes to pain, we're going to do our PQRST. Everybody's familiar with that. Cough, you want to ask if it is productive or non-productive. We want to know when it happens, how often it happens, how long it lasts. If there is a lot of sputum, maybe is it in the morning, is it throughout the day? If they can provide a sputum sample, you want to make sure you're looking at the color, consistency, if there's an odor, volume, all those things. That can help understand if it's purulent, is it infection, or is it something else? If the patient does not have a productive cough, which we would call like a dry cough, that could be from a lot of different things, but it could be asthma, a virus, or maybe seasonal allergies. Asking about changes in weight. So a patient who may have had recent weight gain and then complains about respiratory issues may have an increased risk for sleep apnea, which is when you pause, intermittent pauses where you're not breathing during sleep. If the patient has experienced recent weight loss, then we want to make sure or assess to see why that is, and if it's related to lack of food intake or decreased food intake, that might be related to a respiratory complaint. Maybe they're very fatigued, short of breath, they're not able to eat like they once did. Then we want to assess for dyspnea. So dyspnea is shortness of breath. And when a patient is reporting this, this is a subjective data from the patient. So we also need objective data to identify the cause, because dyspnea or shortness of breath can actually be caused by other things other than a respiratory condition such as anxiety. So we want to definitely make sure we ask the patient what else is going on at that time so we can get more details. Okay, gathering data about the patient's health history. That's going to include current medications, prescribed medications, herbal supplements, vitamins, anything over the counter the patient is taking should be documented. Patients that have chronic respiratory disease should be asked about any type of recent changes in medications, including dosage or maybe the frequency. Any changes could be related to the patient's respiratory status. So we just want to make sure we have a good idea of all angles. Allergies, the environment, food, medications can all cause allergies. So environmental allergies can be found inside the home or outside the home. It can be all kinds of things, and these can cause shortness of breath, wheezing, or cough. So we definitely want to ask a patient about that. Prior medical history, this is going to include any type of recent acute illness or respiratory infection or any other chronic disease process. The patient's immunization status should be evaluated and make sure that they're up to date on their immunizations, like the pneumococcal, influenza, pertussis, those type of things. And let's see, previous surgeries. So these are important because they can impact their respiratory system. So if they've had a lung surgery or they've had like a lobectomy or a laryngectomy, all of those respiratory parts, anything tampered with, and that could cause an issue. Family history. Some respiratory conditions have a genetic predisposition, like many other conditions, so we want to make sure we check on that. Occupation, and area of residence. So certain occupations and certain places where you live can contribute to, respiratory disease processes. So if you work in an environment that has a lot of dust or other kind of things that you will inhale in the environment, then, that can cause respiratory clinical manifestations. And so we definitely want to ask, what kind of work do you do? Smoking, this is huge because it can cause so much damage to the respiratory system. So we want to make sure that we're asking not only do you smoke now, but if you don't smoke, did you ever smoke in the past, and how many packs per day? Social history. So this is going to include alcohol and drug use, and we just want to evaluate how frequent, how much, number of years. A lot of these type of drugs, you can actually smoke them or inhale them, so that might contribute to some type of respiratory illness. Recent travel. So especially recent travel out of the country to a place that like impoverished areas, which are high risk for coming in contact with infectious respiratory diseases like tuberculosis. So any kind of symptoms that happen after travel is a red flag for you to, ask more questions. Then we have the physical assessment. Again, I hope this is all review for you. We are going to start with inspection. So we have speech. Remember, the air movement when we inhale and exhale stimulates our vocal cords. So when we assess a patient's speech, they should be able to speak freely in full and complete sentences. Patients that are in respiratory distress often have time speaking in sentences because of that shortness of breath. We have clubbing of fingernails. I think you all are familiar with that. That can indicate some type of chronic respiratory dysfunction, like chronic hypoxia. Could be found with COPD. The nose, the mouth, and the neck, you want to make sure that you're looking for symmetry in the nose and the size. Each nair should be inspected for like discharge and signs of inflammation. Mucous membranes should be checked for color. We know that pale or cyanotic mucous membranes can indicate tissue hypoxia, which is not good. And then we also want to check inside the mouth for sores, bleeding, or any kind of masses. We want to look at the color, consistency of the mouth itself. It should be pink and moist. If it is dry, cracked, or have sticky mucous membranes, that could be a sign of dehydration. Also, mucous membranes that are pale or cyanotic, which is like a blue color, may indicate tissue hypoxia, which is not good. You should look at the neck for symmetry, any kind of discoloration, masses, cyanosis, and swelling. The position of the trachea, because that's our windpipe, so that's going to be included on our inspection when we're assessing the respiratory system. And of course, our vital signs, so specifically the patient's respiratory pattern, respiratory rate and depth, and effort. So those are things that we should be looking at anyways, but especially when we are doing a focused respiratory assessment. We should also take note of signs of retractions, that's a type of breathing, nasal flaring, and the use of accessory muscles, because that can mean they're having issues breathing. Then we have palpation. So we have trachea, crepitus, thorax. So palpation, we should lightly palpate the trachea to make sure it's midline and non-tender. After the trachea, you should palpate the anterior and posterior thorax to assess for pain, crepitus masses, and deformities. So crepitus happens when air is trapped under the skin, and it kind of is like a crackling feeling. This can be caused by pneumothorax or a trauma to the chest. When you're palpating the thorax, you can assess for equal expansion of the lungs by placing both hands on the posterior thorax, like this picture shows here in the bottom left, having the patient inhale and exhale. As the patient breathes, both of your hands should rise equally during inspiration and return to the same rate during expiration. Again, I hope this is all review for you. And then here in this picture, you see what tactile fremitus is. So if you remember, this is vocal tactile fremitus, and it's when you're palpating the chest wall and you're looking for changes in the intensity of vibrations when that patient, says that phrase that you ask them to say. And when there are changes in this, it can indicate some type of something going on with the lungs. So some causes can be excess air pockets in the lungs or a thickness of the chest wall that can cause decreased fremitus. And causes of increased fremitus can be lung consolidation. So this is usually like when inside the lungs you have like fluid, even blood, exudate, wetness. So this is quite a common something that you'll hear, tactile fremitus, when we are assessing the lungs when there's something going on in there. Next is a review of breath sounds and what you would hear depending on where you would place your stethoscope. So if you look in this picture here on the left, all these little B's are bronchial sounds. So if you placed your stethoscope here and you can hear the movement of air, you're listening to bronchial sounds. Then here you see all these V's, pretty much outlines the whole lung. These are vesicular sounds. Okay, so pretty much you're safe to say that you're listening to vesicular sounds if you're placing your stethoscope over the lungs. And these are described as soft blowing or rustling sounds, breezy sounds. Okay, so these are really easy to hear. So if you just place your stethoscope on yourself or a family member anywhere over the lung, you're listening to vesicular sounds. Then let's look at bronchovesicular. So vesicular are still vesicular technically, but there are bronchioles. Our bronchioles, if you see in this picture right here, is actually protected by our sternum, our bone. And we cannot place a stethoscope over bone. So the way we're going to listen to it is right next to the sternum, right here where you see this BV. Okay, but even though it's bronchovesicular, we still consider this whole area vesicular. Bronchial alone would be up here on the neck area. And then this picture down here, this says ill, so sick, and this says well, so they're not sick. And it just gives you another little description of different sounds you may hear. So rhonchi, coarse, low-pitched, made clear with cough. So if you're placing your stethoscope and you're listening and it kind of sounds, like that, you want to ask the patient if they can cough, because if they can cough and they clear it, then you know that's rhonchi. Then we have wheezing. So wheezing, different textbooks describe it differently. On the next page, you'll see the way your textbook describes it, but it's often described as musical whistling, high-pitched, okay? And then crackles, fine crackling, high-pitched. We're familiar with that one. And this is table 23.4, abnormal or adventitious lung sounds. So you can kind of go through this and just read what the characteristic description is for each one. Moving on to diagnostic studies. Again, this is for the respiratory system. ABGs, arterial blood gas, and we're going to go into this more later. So right now, you should be familiar with the PaCO2, the pH, HCO3, and PaO2. So that's partial pressure of carbon dioxide, our pH, bicarbonate, and partial pressure of oxygen. Okay, that's what we call these when we're referring to arterial blood. Some more diagnostic studies. Pulse ox. So this is the most common, probably the one you're most familiar with. So this is going to give you the saturation of hemoglobin with oxygen. Our goal is going to be 95% to 99%. If you ever have a monitor like this at the bedside where you can see the patient's O2 sat on the screen, you see where this arrow is. This is a waveform, a pulse oximeter waveform. And this is a normal one, kind of looks like this one here. And that means that the probe is on correctly and there is nice perfusion there. And then you can see low perfusion. It just means there's something wrong with the probe, or maybe the patient doesn't have very good perfusion. It's, maybe they're hypovolemic or very anemic. And then noise artifact and motion artifact. That's kind of like maybe the finger's dirty, the patient's moving around a lot, there's not a secure connection. So when you look at one of these screens, that's just another thing that you can look at to make sure that this number, your SpO2, is as accurate as possible. Then we have capnography and capnometry, which is pretty much can be used interchangeably. This is where we are continuously monitoring carbon dioxide. So we're not going to get too much into this. It's something that you would go over in advanced Med-Surg, but you can either have an intubated patient, okay, so a patient with a breathing tube down their trachea on a ventilator, or you can have a patient with a special mask that also has this feature of capnography. And this little sensor here is measuring carbon dioxide exhaled. Okay, so that will let us know if the patient is adequately exhaling carbon dioxide. And the normal values for patients, regardless of age, size, race, sex, is between 35 and 45 millimeters of mercury. Okay, so on this screen we have 38. That means that patient is blowing off a normal amount of oxygen, carbon dioxide. More diagnostic studies related to the respiratory system. We have a sputum analysis. You guys are familiar with this. So if you have a patient that has a productive cough, or maybe you have a patient that has a tracheostomy that you're suctioning a lot of secretions out of, doctor might order a sputum analysis. So this is something you want to maintain sterility. So sterile, you want a sterile cup here that they can either spit into, or this one where we can use for suction. Just remember, sputum is thick and sticky. It is not thin and watery. So we don't want saliva, we want sputum. And if the patient can produce that first thing in the morning, that would be best. If the patient did provide a sample, we want to look at it for color, consistency, and presence of blood, which is hemoptysis. So if a patient has blood in their sputum, that is reportable. We want to report that because that can mean something much more, something is bad, something is not good. So we want to report that. Chest x-ray. So this can actually help with a lot of different organs. So the heart, the lungs, and the pleural space. So this is commonly ordered in the hospital. Sometimes patients get daily chest x-rays. This can show masses, air or fluid in the pleural space. It can show pneumonia, atelectasis, and it can even show TB infections. So these aren't all inclusive. Sometimes you can have a chest x-ray that shows, maybe possible TB, but we still need to do, our sputum culture to confirm. So this is just another tool. Then we have our pulmonary function test. We call this PFT. This is going to measure lung volumes and lung functioning. So I'm going to go through this a little bit on the next slide so that you can understand what this little graph here is actually showing. Once you understand what it's measuring, then you kind of get like, okay, that's why we measure it. That's how this relates to this respiratory condition. Okay, so let's look at this graph. So this line here is representing inhalation and exhalation. Okay, so follow along with me. We are inhaling, okay? Inhale, inhale, and then we're exhaling. We're inhaling, we're exhaling. And this is when we are at rest. This is normal breathing pattern. Okay, inhale, exhale, inhale, exhale. Now, what if I asked you to take a very, very deep breath, to see if you can fill your lungs as much as you can? Okay, so you inhale, 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 and this is as much as you can inhale. Okay, then you exhale. Then I ask you to exhale as much as you can. Get all the air out as you can. So this is this line. Exhale, exhale, and then you go back up to your normal in and out. Okay, so this amount here that you were inhaling as much as you could, from this point down to this point here is our inspiratory reserve volume. Okay, so this volume, we're not really using it, but if we had to, we could inhale this amount. Okay, then we have from this one down to here. And this is our expiratory reserve volume. So it's kind of like the opposite. This is how much we could actually breathe out of our lungs, getting that air out of our lungs. But you can see that down here, there's still space. So this is the amount of air that is always in our lungs. We can't breathe that out, okay? That kind of stays there. It's kind of like blowing up a balloon and you're never really emptying that balloon completely. We always have a pocket of air. And that's going to be called our residual volume. So this, where we're breathing normal, in, out, just our normal breathing, that is our tidal volume. Okay, that's like our regular amount of air that we breathe in and out at rest. Then you can see these other names here, vital capacity. So that's going to be this whole amount combined together. So the amount that we can inhale all the way and then exhale all the way, that's our vital capacity. And everything all together is going to be our total lung capacity. So that's what that means. Now, you don't have to remember this chart. However, there are certain conditions where they're going to have a pulmonary function test and maybe they're going to use tidal volume. And then you'll think, okay, tidal volume, that's just what the amount of air that goes in and goes out. Then we have our, expiratory reserve volume. Okay, that's the amount of air that we can exhale, voluntarily, but we always have this pocket. So you want to be a little bit familiar, but if a condition that you see on another slide mentions one of these, then you may want to come back just so that you can, like, okay, that's what that means. Okay, but you don't have to memorize this whole thing. Just understand the concept and how it applies to certain conditions if it's mentioned in those conditions. More diagnostic studies, bronchoscopy. So bronchoscopy is when the patient comes in and they take a scope, a bronchoscope, and they put it down either the nose or the mouth, and they take a look down your respiratory tract, so down your windpipe, your trachea, into those big bronchioles like you see in this picture. This can check the airways, it can check for any abnormalities, it can also take a sample like for a biopsy. So very helpful to visualize those bronchioles. So your role as the RN is after the procedure. So for this procedure, you can see that it's going down the esophagus. So these patients will usually have a numbing spray to numb them up so that they, to suppress the gag reflex during this procedure. And when they wake up, their gag reflex may still be asleep or numb. So we don't want them to aspirate. So we are going to check their gag reflex before we let them have anything to eat or drink. Next is thoracentesis. So this is done posteriorly, like seen in this picture. The patient is sitting upright. They're usually kind of hunched over a table or maybe hugging a pillow. There's an ultrasound guide here, and then a needle is inserted to aspirate some of that fluid in the pleural space. And oftentimes the fluid that they take out, they will send it off to be cultured. Next is a lung biopsy. I think we're all familiar with what a biopsy is. Lung biopsies are typically done under CT guidance, like seen here in this picture. So just like with any puncture post-procedure, we just want to make sure we look out for any bleeding, and if there's any pain, we want to make sure the patient is comfortable. And this is our last slide, and that concludes this chapter.